morning, everybody. How are you all? That's great to hear. So for today's program, I want to thank 3 of the companies that provided us their support to be able to bring this program to you. And the first one is Sanofi-Genzyme, and I hope that you all thank them as well. Clap, clap. And that's a lot out of you. And then we also have Biogen and Mallinckrodt, and all 3 of them wanted us to have this series called Balance brought to various portions of the United States. And so they've supported us in what we're doing. We just held this program a week and a half ago in San Diego, 2 nights ago in Savannah. And in Savannah, you know, we expected a small crowd, yet we had 58 people there to attend. It was really nice. Okay, next. We want to get started with this program because we are running a little bit behind. We have 3 different speakers today. One is Colinas Sanders, and she's a neurologist that many of you know from here in Jacksonville. And after Kalina speaks or Dr. Sanders speaks for 45 minutes, we'll then do the Q&A. And after her, we'll have Megan Weigel. And after Megan, we'll have Jeff Siegel. So it's a good afternoon, good morning, and good afternoon that you all will get lots of information from. I want to introduce Dr. Sanders. Dr. Sanders has a medical degree from the University of Texas, HSC San Antonio, neurology residency at University of Florida in Jacksonville. She's received several exemplary teacher awards while faculty at University of Florida, Jacksonville, and she's now in practice at Baptist Neurology on the Beaches. She has special interest in spasticity management and health literacy. So let's welcome Dr. Sanders. There, and thank you for coming.
Thank you. So when I found out that this was going on YouTube, I told my daughters, I said, I think I'm going to go viral today. And my youngest, who wants to be a YouTuber, said, yes. So I have been tasked to present really an overview of multiple sclerosis, discuss relapses and how we address those, as well as some symptom management. And I've been asked to do this in 45 minutes, and those of you who know me know I'm a little bit more verbose than that, so I'm going to speed along through some of the slides. So hopefully at the end, during the question and answer, you'll be able to ask those filler-in information that I kind of breeze through. So without further ado, I'm going to continue with the slide. And he said this works. I get this nice podium. Oh, yes. So we're going to talk really about multiple sclerosis. And as he gets the slides together, a lot of my initial slides are really just kind of a basic overview of what MS is. And as many of you may know, it is an immune-mediated chronic condition of the central nervous system. And that central nervous system involves the brain, the spinal cord, but we also can't forget that the optic nerve is an extension of the central nervous system. Awesome, we've got my disclosures there. You're all experts in MS now. We're done. But as many of you know, the immune system is really meant to fight bacteria, viruses, and surveillance for cancers. And so what happens in multiple sclerosis, the immune system becomes misguided. And the immune system, instead of doing what it was supposed to do, goes and attacks the central nervous system. Now, in the central nervous system, those nerve cells or those neurons are covered by myelin, and it can cause demyelination. Underneath the myelin is the axons, and the axons are important for the cell body to remain alive. When the axons become transected and they get cut, the cell body dies, and that leads to some of the disability that we see with multiple sclerosis as well as symptoms.
Just ask for the next slide.
Oh, next slide. I already discussed this slide. You can hit click. In case you didn't know, brain and spinal cord as well as optic nerve. And this is the central nervous system. Really, the neuron and the axons are important for communicating the information from side to side. Next slide. So what happens when those autoimmune or autoreactive T cells enter to the nervous system? Can you hit the next button, please? They become activated and they release these cytokines, which are the green structures on the screen, and they eat away at the myelin, the axon, and the oligodendrocyte that makes the myelin. Next slide. And so this is what I was mentioning before, is that when you have a destruction of the myelin, it interrupts the electrical signal, and so the one nerve cell cannot talk to the next nerve cell. And if you have axonal loss, then the cell body dies, and that nerve cell does not regenerate. Next slide. So who does this happen to? 2.5 million people worldwide have multiple sclerosis. And the most updated numbers here in the United States is close to 1 million people in the United States have multiple sclerosis. And it's not as rare as we thought it once was. It really is the diagnosis of the young female. The average age of diagnosis is around 30 years of age, but about 10% of patients are pediatric and below the age of 18. And there are some patients who develop symptoms of multiple sclerosis after the age of 50. It really is predominantly a female disorder. That gender gap is widening. It's felt to be more like 3 to 1, more likely to be in female. It's more common in Caucasian population and people of Northern European descent. Next slide. So what causes multiple sclerosis? Can you click? I have some animation there. We don't really know. Can you just click like 3 times? But we do think, though, it's a combination of environmental factors, whether that's lack of vitamin D, exposure to smoking, personal exposure, I should say, and an abnormal balance of gut microbiome. In someone who has maybe a previous exposure to a virus, the most commonly linked virus is the Epstein-Barr virus. Can you click one more time? And in someone who has a genetic susceptibility of developing multiple sclerosis, we've actually identified over 200 different genes that may be implicated in the susceptibility of developing multiple sclerosis, and have identified one particular HLA gene where there seems to be almost a 2 to 3 fold increase in your likelihood of developing MS. But genetics don't play the complete role. If we look at monozygotic twins, the concordance rate in someone who shares almost the same amount of DNA as the other person is only about 30%. And so it really is a combination of all of these factors, including environment and infection exposure. Next slide. So in someone who has the wrong combination of these factors, they develop symptoms of MS. And it really depends on where in the central nervous system the inflammatory cells like to attack. So it can be anything from the visual symptoms with optic neuritis and painful vision loss, double vision. It can also present as stroke-like symptoms, but much more gradual onset. It can develop weakness on one side. Oftentimes, if it's a spinal cord event, you can develop numbness in both of your legs, and it can travel up to your chest and even into your arms. There's also bowel and bladder difficulties that a person can have, and we'll talk about those in a little bit. Next slide. So what type of multiple sclerosis? That's a very common question I get all the time. What type of MS do I have? And we've really changed how we're categorizing MS now. And we're starting really early on as clinically isolated syndrome. And then we have relapsing remitting MS, secondary progressive MS, as well as primary progressive. One category you may not see up there is the relapsing progressive, which we've kind of taken away. Next slide. So when we look at the categorization of multiple sclerosis, we're able to really kind of be much more specific and person dependent. And so in a person, we can actually describe your MS based on how you behaved over the last 6 months or a year. So if a person has clinically isolated syndrome, we can now say that you're not active, which means you've not had any further clinical events or MRI relapses, or you can have some activity. Now, if you have clinically isolated syndrome, your first event, and you now have a subsequent event, we can now transition you into relapsing remitting MS, which can also be not active, which means no clinical disease activity, no MRI changes, or any worsening of your physical symptoms, or you can be active if you have one of those. Next slide. Likewise, in the progressive category, so whether or not you're secondary progressive MS or primary progressive MS, we can now describe you in much more detail. So over the last year, we can say that you have progressive MS, but you're active with progression. That means you've had maybe a clinical relapse or a new MRI changes, but we've also seen a slow decline in your physical functioning over that time course. You can also be active without progression, which means your physical exam hasn't changed, but you've had new MRI changes or you've had a clinical event. You can be not active, but with progression. So no changes on your MRI, but we can still see on your physical exam that you have had a decline in your ability to function. And our hope is that we can tell you that you have stable disease. That means even though you have a primary or secondary progressive form of the condition, you're not active, which means you're not having MRI activity or clinical exacerbations, and you're not having progression in your physical exam. Next slide. So one of the interesting ways that we're starting to really describe MS is really with this topographical model of MS. It really helps us to visualize what goes on in a person's body and how their disease course happens. And so you can think about your MS as a pool or the ocean. Maybe the ocean, because this is kind of has a difference in the depth of the clinical symptoms. So if you think about your brain as a pool and it's filled with water, the top line that's marked with B is your clinical reserve. That's how much your brain can handle. And the water line is really your clinical threshold. So activity below the clinical threshold or that water line is asymptomatic. We can't see it from the outside. Now, if your clinical symptoms go above your clinical threshold, now we're looking at the peaks where we see A. And if I had a pointer, I'd be pointing to it. And so really when you have clinical symptoms that go beyond your clinical threshold, we can see them as, oh, awesome. Thank you. It does point. There we go. We can see your clinical activity outwardly. Now, if we clear up the water a little bit, we can see really underneath the surface that there's much more clinical activity that's going on your MRI. It just has not reached that clinical threshold where we can see it on an outward basis. There's also this thought that maybe the location of your lesion is important. So there are areas in the brain in the deeper part of the ocean or the deeper part of the pool where you can sustain a lot of hits. You can have a number of lesions without having any clinical symptoms. But there are areas in the brain such as the spinal cord and the brainstem, the optic nerve, where it can only take one event and you have significant difficulties. So not only is it important the number of lesions that you have, also the location of the lesions is important. And then likewise your reserve threshold, whether or not these symptoms are clinically or outwardly noticeable. Next slide. So when we think about one of the hallmarks of relapsing multiple sclerosis is to have relapses. And we call them different things. We call them flare-ups, we call them attacks, we call them exacerbations. And really what a relapse is a new or significantly worsening focal neurological disturbance. And it has to last at least 24 hours without an alternate diagnosis or explanation. And it's also important that you've not had a previous relapse in the last 30 days. If these are grouped together, we actually consider them one relapse. Next slide. So the course of a relapse is variable. It differs from person to person. It differs from relapse to relapse. But typically, they resolve spontaneously within days to weeks, and the recovery may be incomplete. So with each relapse, there is a possibility of sustained disability over time. Next slide. So do we treat these clinical relapses? So we do have various different options, and I'll go over it in the next slide. But really, the goal of the treatment is to decrease the duration and the intensity of the neurological dysfunction. Unfortunately, treating the relapse does not always ensure a full recovery from your relapse, and so therefore not all relapses require treatment. Next slide. So if we do choose to treat your relapse, we have a number of different ways to do that. We have IV or oral methylprednisolone or solumedrol, which can be given for 3 to 5 days. We can also use ACTH as a gel called Acthar, also for 5 days. Acthar is given subcutaneously underneath the skin, very similar to maybe your Copaxone or your Rebif injections. Now, if your relapse is severe and we've tried these two mechanisms and we need to do something more, we do have other more invasive type procedures that we can do to help clear your body of those autoreactive and inflammatory T cells. So we can use IVIG, which is also given intravenously, and then plasma exchange. Plasma exchange is a unique thing in which we connect your body to a machine and we flush your blood out, and we try to remove as much of those inflammatory particles as we can, and then we give you back your blood. And probably just as important as any therapy we can give you or prescription we can give you is to have physical and occupational therapy. Next slide. It is important to know whether or not you're having a true relapse or what we call a pseudo relapse. So there are instances where you may have increase in your core body temperature. Maybe you have an infection or a febrile illness. Maybe you exercise too much, or you've been exposed to excessive amount of heat. And you might find that your previous symptom that previously went away has now returned. But usually in a pseudo relapse, if you resolve whatever incident has happened, then your symptoms improve. So you get over your infection, or you take Tylenol and your fever goes down, your symptoms should improve and almost resolve. Or if you rest and hydrate, we should see those. If that is the case, then generally we don't consider that a new inflammatory lesion, and we call it a pseudo relapse. Next slide. So I mentioned also that there is subclinical activity that can happen underneath the surface. So therefore, MRI is extremely important, not only in the diagnosis of your disease, but also the surveillance to see if we're controlling your disease activity. So as you can see here in the slide, that there are many activity or changes on the MRI that is not clinically relevant to us. It's felt that for every one clinical event, there is 5 to 10 new lesions on your MRI. So for those of you who don't like to get MRIs that often, you can see the importance of it in this slide. Next slide. So I'd put in a couple of slides for MRIs. I think it's important for you to understand what your MRI looks like, how it has changed over time, and what we are actually looking for when we send you into that tube. So essentially on an MRI, the brain tissue is gray, but the MS lesions are white. They're usually very ovoid lesions, and they like to hang around the ventricles or the cavities that hold spinal fluid. They tend to extend perpendicular from the axis of that ventricle, but they can also occur more peripherally. Next slide. And closer to the edge. We do like to use gadolinium. That helps us to see if there is an active lesion. So generally, if a lesion occurred within the last 4 to 6 weeks, and we give you the gadolinium, which is the dye, we will see that lesion enhanced. That helps us to understand how inflammatory and how active you are. Next slide. The spinal cord is also very important. If you remember going back to the topographical slide I showed you, how there are areas that are very eloquent and only require maybe even a solitary lesion to produce significant symptoms. You can see here on this MRI how we have the brain, and it all gets funneled down into the spinal cord, and you can see the area of the spinal cord compared to the brain, and how you can hit a lot of different different functions with a solitary lesion. So in this picture here, this patient here has just one lesion here and can have significant difficulties. Next slide. Also very important is not only to know how many lesions you have or those T2, those bright spots, is to also understand how many black holes you have. And so when we look at an MRI and we look at the T1 sequence, we can see here, instead of seeing bright, we actually see dark. When there is transaction of the axon and the cell body dies, it leaves a hole. It gets filled in with spinal fluid. So when we look on a T2, we see it as a black hole. When we look at it on a T2 in which the spinal fluid is white, it also becomes white. This lets us know how much disability possibly you can accumulate over time. Next slide. So it's important to know also how you progress over time. So in this picture of the topographical model of MS, what we see here is that the water level at year 5 after diagnosis is at 1 level, but however over time you do lose some of your reserve in the brain and how much it can handle, and by 20 years that water level decreases. So when we look at disability progression over time, we think about a neurodegenerative process, but we also have to think about a loss of reserve in your brain. So maybe you're developing worsening symptoms, not only because you're having neurodegeneration, but also because we're starting to uncover lesions that were there in the brain that just did not meet the clinical threshold. And now that your reserve has declined over time, we are now able to see the symptoms that arise from those areas. Next slide. So when we look at disability progression over time, we use a scale called an EDSS, an Expanded Disability Status Scale, and it really allows us to describe your disability based on your level of function. We usually do a neurological exam and have you walk several meters to get this score, and we're able to tell you whether or not you have no disability, whether you have a relatively severe disability, or have confinement to a mobility device such as a wheelchair or even the bed. Next slide. Can you click a couple of times? One more time. Excellent. And so really the variation in that progression occurs very differently from person to person. I always say if you see one person with MS, you see one person with MS. Everyone has a difference in their progression over time. There is a difference whether you have relapsing remitting disease versus whether you have primary progressive disease. So we do know in patients that have primary progressive disease, they progress at a much faster rate than patients with relapsing remitting disease. In those patients who do have relapsing remitting disease, we also see that there's a variation in how they progress over time. So if you think back to the EDSS that I just showed you, we're able to arbitrarily give a cutoff of an EDSS of 3, which shows a moderate disability, and we can look to see retrospectively how fast a person progresses to that state. And so when we look at disability progression for our relapsing remitting patients, we really think there's 2 phases. There's this early phase in which it takes how long it takes you to get from an EDSS of 0 to an EDSS of 3, and we find that phase is actually variable. It depends on the number of relapses you've had over that time course. It depends also on whether you've recovered from your relapses during that time period. We also find that it may be variable based on your age and even your gender. But what we found though is once you've hit that moderate disability stage or phase, that the progression seems to be more uniform. So that irregardless of the number of relapses, your age or gender, we see that the progression occurs almost at the same rate. It's unclear whether these 2 phases exist in primary progressive MS. Next slide. So I mentioned really the 3 key features of multiple sclerosis: relapses, MRI changes, and disability progression. And so really what our goal has been over the years is to determine what can we do to prevent those? What can we do to prevent relapses, MRI changes, and disability progression? So a lot of scientists have worked really hard to make that, and before 1993, we really didn't have anything that significantly altered that disease process. And so this might have been a conversation that you had with your provider before 1993. Your doctor says after they've diagnosed you with MS, they say, don't worry, all you need is a revolutionary miracle drug that will be the medical discovery of the century. I'll see what I can whip up. Next slide. And they have whipped up quite a few of those miracle drugs that have been very game-changing therapies for multiple sclerosis. And so we now have, depending on how you categorize them, 14, 15 different disease-modifying therapies. Now, I could spend an hour just on this slide, and I won't bore you too much, plus I have 45 minutes. But really, when we look at the disease-modifying therapies, we can group them into really three different modes of administration. We have our injectables, which are our platform agents, our interferons, and our glutathione or acetate, and we have different variable administration of those. We have beta-seron and Extavia. In our interferon beta-1A, we have Avonex, Rebif, and Plegridy. In glutathione or acetate, we now have a generic glutathione or acetate as well as Glatopa. And Daclizumab is a subcutaneous injection given once a month. In our oral categories, we have fingolimod or Gilenya, teriflunomide, and dimethyl fumarate. And now we have three intravenous mechanisms of actions. We have natalizumab, alemtuzumab, and ocrelizumab. I went to school just to pronounce those words. But they really have different ways in how they impact the immune system. They work on not only T cells for most of our medications, but we do have some of our medicines now that impact B cell function as well. They all have been proven to show a significant reduction in annualized relapse rates. They do very well at decreasing the number of new or enlarging T2 lesions and oftentimes GAD-enhancing lesions, and have a variable impact on disability progression over time. Next slide. So what do our disease-modifying therapies do? I mentioned before, they decrease relapse rates, they have an impact on our MRI activity, and we hope that they reduce accumulation of disability over time. But what do they not do? Unfortunately, none of our disease-modifying therapies have been proven to repair the myelin. They don't regenerate axons that have already been lost, and we know that none of them are cures for the disease, and so they're not 100% effective. Therefore, next slide. You're left with some symptoms from your MS. So as you have your MS relapse, you can get better, but oftentimes you're left with some residual symptoms. You may develop symptoms in the absence of a relapse, and we know that that is true, and there's many of them. If we went around the room, probably many of you could relate to a lot of these that are on the screen. Luckily for you, I won't talk about them all. Can you click it one more time? I will focus, though, primarily on the ones on the left-hand column. I'm going to talk about fatigue, spasticity, mobility and ambulation difficulties, as well as bladder and bowel function, and then I'll end with a couple of slides on pain. Next slide. So fatigue. I won't ask you to raise hands on how many can relate to this. Next slide. But really, up to 80% of patients with multiple sclerosis will develop some sort of fatigue over time. And this is really defined as a lack of physical and mental energy. Next slide. We really have to decide how we look at fatigue, because not all of it may be related to multiple sclerosis. So we need to understand whether you have low daytime energy or poor nighttime sleep. So that's a big thing for our society, is getting regular rest. So insomnia is a big cause for daytime sleepiness and fatigue. We also know that mood disorders such as anxiety and depression can have an impact on your energy level. trouble. You may be dealing with significant amount of spasticity and stiffness, so it takes you a lot more to get around and maneuver around your home or doing your activities of daily living. Pain can also significantly impact your ability to function, which will drain you of your energy. If you're having frequent urination, particularly at nighttime, you're not getting regular rest. And if you're having restless leg type symptoms, you can also have difficulties with getting good, solid sleep at nighttime, which can relate into significant daytime fatigue. Next slide. But there are also other additional causes of fatigue. You can have short-circuiting. We call that the Hutos phenomenon. So really during times when your nervous system has to function and it's on overdrive, it just can't keep up, and we call that short-circuiting. You could be deconditioned. I say all the time, if you've heard my talks before, the less you move, the less you'll move. And the less you move, the more deconditioned you get. So it takes more energy to move, and you'll lose some of that. And I mentioned depression before. Next slide. But there is that MS-related fatigue. That's what we call lassitude. Now, this fatigue can occur on a daily basis. It can even occur after you've slept wonderfully the night before. You wake up, you stretch, and you say, I feel wonderful, I slept well. And your spouse or your partner may say, well, you snored all night. But shortly after awakening, maybe mid-morning, it just hits you. And it can hit you like a ton of bricks, and you just cannot move. You have difficulty with thinking. You have difficulty with functioning, and there's no way that you could have prevented it. We know that it gets worse as the course of the day. We know that it can be impacted by heat and humidity, and we know that it can be much more severe than just the I'm tired feeling. Next. So how do we manage this? So really what you might find is over the next few slides that we are looking at a theme of lifestyle modification, so adjustments. So really the biggest thing in this slide is to know that you have to get rid of those non-essentials. You have to prioritize your activities, understanding how your body functions and when it's going to let you do it and when it's not going to let you do it, and then tailoring your day based on what your body has told you. And so you want to develop, again, healthy sleep habits and prioritizing your activities. Oh, also very important, exercise. So exercise can help build up those natural hormones and serotonin levels that can help give you that extra boost of energy that you might need. If you're smoking, we want to get good oxygenated blood to the brain, so quitting that will help to give you as much reserve as you can have. Eating healthy and not skipping meals, and obviously staying cool and with low body temperature. Next slide. But there are some medical therapies. If you've done that, you said, look, I've given my spouse everything that I could possibly give them, and I do absolutely nothing all day, but I'm still tired. There are some medications that can be helpful. None of them are specific to MS, and so we use oftentimes amantadine, which is an antiviral or an anti-Parkinson's medication. There are some medicines that are used for obstructive sleep apnea and narcolepsy. Those are Provigil and Nuvigil. Some of our antidepressants, so very similar to the increase in serotonin that you can receive with physical exercise, we can help your body out with that with pharmacological agents. So some things like Prozac, Paxil, and Zoloft can be helpful. And then in those rare cases, stimulant medications can be used. Next slide. So what about mobility and ambulation? Next slide. Many of you may be know that with untreated multiple sclerosis, there can be a significant decline in functioning over time. We know if it's left untreated, within 15 years, about 50% of patients will require assistance of at least of a cane to ambulate, and oftentimes a wheelchair. And if we extend that out 25 years untreated, up to 90% of patients will require some sort of assistive device to ambulate. The good news, if we're making changes to this, this with our disease-modifying therapies, but still something that we have to discuss. Next slide. So really your gait impairment from your MS can be caused by a number of different factors. Weakness, you may have developed foot drop. The spasticity and the muscle stiffness can impair your ability to function appropriately. Having that fatigue, also proprioceptive loss. So you have numbness in your feet and you can't feel the floor. So your body has no idea where it is in space, and so that affects your balance and can lead to things like ataxia. Cerebellar dysfunction can do that as well as vision loss. So oftentimes our patients will take more short steps, they lack full range of motion. Oftentimes you're dragging that leg along with you, you're saying, come on, come on. And unfortunately with mobility difficulties, the biggest sequelae that we get concerned with is falls. Next slide. So I mentioned before severe ataxia. Now it can not only be with your limbs or your arms and legs, but also can be with your trunk. So your ability to maintain an upright position significantly impacts your ability to mobilize. Next slide. So how do we manage this? Again, my theme here is exercise, lifestyle modification, and things that help to provide that you're moving around the safest way you can. And so conditioning programs can be helpful, adaptive exercises, and we do have wonderful programs in the area that can help facilitate that. If you have focal weakness, such as foot drop, we can use orthotics or AFOs. Sometimes if you have more proximal weakness, we can use stabilizers to kind of help maintain that upright position so that you can use those muscles to start with your gating. And then also if we've lost significant ability to ambulate, you still want to be mobile. So we have to learn to get in and out of our mobility devices such as our wheelchair. So assistive devices also important are canes, crutches, walkers, and I mentioned those wheelchairs. Next slide. So in those patients who are interested in pharmacological ways of treating your ambulation, there is one, dalfampridine. It's also marketed as Ampera. This is a medication that has been shown to improve walking speed in patients with multiple sclerosis. So in the clinical trial, about a third or a little over a third of patients responded to this medication. And in those who responded, had an increase in their walking speed by 25%. Now, this is not a disease-modifying therapy. This is a symptomatic therapy. And what it does is it helps to allow the electrical signal to conduct better. So our patients, in whom are responders for it, have a significant improvement in their ability to ambulate. And that might be the difference between making it to the toilet or not. Next slide. It is a twice-a-day medication, but we do have to caution that if you had a history of seizures, that there is an increased risk for that, as well if you have certain kidney dysfunctions, we have to caution or even restrict the use of this medication in those. Next slide. So I mentioned spasticity before. It has a big impact on your ability to mobilize and move about. If it's severe enough, it can cause contractures, which is what we see here in this slide here. Next slide. So spasticity can be variable. It could be just stiffness in the muscle. It doesn't necessarily have to result in an inability to move a joint. It can also present as involuntary muscle spasms. When we look at spasticity in multiple sclerosis and things that affect the nervous system, we find that the increased tone or that muscle stiffness is primarily in the flexors of the upper extremity, and so that's why the arm is oftentimes kept very close to the body, and in the extenders in the legs, and that's why oftentimes you have to swing that leg over. Next slide. Spasticity is felt to be have an impact in up to 80% of our patients with multiple sclerosis to some degree. I would say that most patients really have those mild muscle stiffness or muscle spasm and involuntary contractures. But again, there can be flexor spasms where your arms want to curl in. And then for some of our patients, there can be extensor spasms where when you're trying to transition from, let's say, your chair to your wheelchair, your legs just go straight out and they don't move. Those are all considered modes of spasticity. Next slide. So really, what are our goals of managing our spasticity? We want to improve function and the ability and your independence. We want to be able to have you walk a little bit better. Also, spasms and spasticity can be painful, so we also want to decrease that for you as well. And then help you be able to do your rehabilitation procedures. Next slide. So how do we do that? We want to avoid things that can increase your spasticity, such as extreme temperatures or sudden movement. Even infections can make your spasms and spasticity worse. We want you stretching multiple times a day and exercising and doing relaxation techniques like yoga and meditation. But if the need should arise, there are some medications that can be helpful. There are procedures that we can do, as well as orthotics that can be helpful. Next slide. So I mentioned that before, exercises and therapy. We can't exclude our pool therapy, which is very nice. Weight bearing, cryotherapy, and electrical stimulation are things that the physical therapist and occupational therapist can do. Next slide. And when we look at medication management, there are a number of different medicines. We can use Baclofen, we can use tizanidine, Flexeril. Those are really all of our, and dantrolene are our antispasmodic medications. But there are other medicines that can help relax the nervous system enough where it helps with the spasticity. And so we can use things like clonazepam and gabapentin, and even some other medicines, anti-seizure medicines like Tegretol or Sinemet. Next slide. Botox is interesting. So it's not only for wrinkles, not only for cosmetic reasons, but can significantly help your ability to move across your joints. And so the FDA has actually approved Botox for not only upper extremity spasticity, but also lower extremity spasticity. Botox is good, though, only for focal types of spasticity. So if your spasticity involves more than one or two muscle groups, then we might need to think about something more invasive like, next slide, a Baclofen pump. So if some people have benefit from Baclofen, but we don't get the benefit that we'd like to get, oftentimes we can give it intrathecally in a pump and are able to use much lower doses and get a much robust effect. Next slide. Bladder and bowel dysfunction is also important. Next slide. It can be a number of issues. Primarily, it's frequency and urgency, also marked with retention and incontinence. Next slide. Your bladder can do a number of different things. It can be small and spastic, failure to store. It can be large and hypertonic and just doesn't want to empty. Or it can be confused, dysynergic. Next slide. So really managing those bladder issues is, again, lifestyle modifications, curtailing how much you drink and how late you drink it. Avoiding caffeine and alcohol can be important. And then if you do have those rare, hopefully incontinent episodes, you can use absorbent materials to help. Next slide. There are medications that are available, and it depends on the type of bladder you have. So having that urodynamic study is extremely important. It helps us to utilize the appropriate medication for you. Next slide. Bowel problems exist, constipation primarily, but there can be overflow diarrhea as well. And then we can work with different medications and other things that can help prevent that. Next slide. I talked about that. Next slide. Pain, that's the last thing. Many of you have probably have heard in the past that MS doesn't cause pain. Next slide. We know that it does, and up to 40 to 50% of our patients have pain, and it's a mixed pattern of pain. It can be neurogenic, and it can be nociceptive. So not only do the nervous system produce pain, but the weakness and the spasticity that yields on your musculoskeletal system can also cause pain. And depending on the type of pain, determines how we manage it. Next slide. And so there are different medications that we can use, anticonvulsants, antidepressants, and even cannabinoids. I didn't say that. Nociceptives, NSAIDs can be helpful in treating that spasticity with antispasmodic medications, as well as utilizing physical therapy, cognitive behavioral therapy, and again, maintaining a healthy lifestyle. Next slide. So really, in conclusion, I've talked a lot about MS. I tried to squeeze it in 45 minutes, and I think I did it. It is an autoimmune condition of the central nervous system. We have drugs that are helpful to reduce relapse rates, MRI activity, and hopefully disability progression over time. But there's still the need to manage our symptoms as they arise, and really keeping a healthy lifestyle is key to the management of multiple sclerosis. Next slide. So really what you can do, you're doing it today, you're staying informed, you're being proactive and asking questions, which we're going to do next. And really I encourage you to adhere to your treatment plan and participate in clinical trials that help us to identify new and emerging therapies. Next slide. Thank you for your attention.
Thank you. Thank you. It's always nice to have a new perspective, isn't it? Thanks again. Anybody have questions? I'm going to run around the room. I need to lose some weight, so I need you to do this to me, okay? Hold your hand up, please, and remember, I'm going to hold the microphone.
The brain reserve decline that you described, is there a timeline from like disease onset to later in life that you can expect that? And do DMTs affect that reserve decline?
Yes, so one of the things that we look at with reserve decline is atrophy. So when we look at your MRI, we can look to see how much the brain is shrinking. We do know that MS brains have a greater rate or a faster rate of atrophy compared to controls. Everyone is different though in that rate. And so I can't necessarily predict for an individual person how fast it happens. But when we look at our disability progression over time, which we think has a connection with that brain reserve, we're looking at in relapsing remitting MS patients at around 10 to 12 years, we start to see that change or the time to having an EDSS of 3, which may correlate with that brain reserve. Yes, we like to think that they do. Yes, so when we look at the natural history of MS, we're seeing a much different picture now. So post-DMT era, we are definitely delaying that progression into things like secondary progressive MS and hopefully preventing that reserve. But again, everyone is different, and I think that there's an innate ability of a person to maintain a certain amount of brain reserve.
Can you tell us a little bit about IVIGs?
So IVIG is a therapy that's used for acute relapses. That's where we see that it has the most robust effect. And so the IVIG is an immunoglobulin which helps to decrease inflammation or that inflammatory process. So in patients in whom have an incomplete recovery from using glucocorticosteroids like solumedrol or prednisone, then that might be utilized during those cases.
Yes. You mentioned the plasma therapy. How effective is plasma therapy?
So again, plasmapheresis or plasma exchange is really at this point indicated in acute relapses. So we find in those patients who again have an incomplete recovery from the steroids, or we've tried Acthar, we've tried solumedrol, and they still have significant disabilities. Oftentimes we will resort to the plasmapheresis. It's a much more invasive procedure and is only done in the hospital. So it's only reserved for those really severe exacerbations. Over here.
Can you tell if bladder problems are caused by MS or something else, and does it matter? Would it be treated the same?
So yes, there are ways to tease that out, and the biggest way we can do that is with the urodynamic study. So with our colleagues in the urology department, we can look and see if it's something that is innate to the nervous system, not giving the electrical communication to the bladder, or maybe you've had some sort of obstruction. So maybe there's something structurally going on with your urethra or your bladder that's preventing that. So it's important to know. Oftentimes, though, we treat them very similarly, but with the urologist's help, we can treat it appropriately.
Question here?
Is there a test for the Epstein-Barr virus?
So yes, there is a test for the Epstein-Barr virus. It's a blood test. We do find that a lot of the population has been exposed to the Epstein-Barr virus. Early epidemiological studies do suggest that MS patients may have a higher likelihood of being exposed to the Epstein-Barr virus. But a large amount of the population who don't have MS have also developed mononucleosis. But yes, there is a test.
Does it matter how long you've had the MS? Does that influence the test for Epstein-Barr?
No, actually, it's the reverse. So what we think is your prior exposure to the Epstein-Barr virus is really what has tricked your immune system to be misguided. So it's the exposure to the Epstein-Barr virus that may predispose you to developing MS. So there's no correlation there in the reverse.
Hi, I suffer from a lot of pain and I take opioids, and I'm very interested in the CBD oils. I just want to know your opinion on that.
So, based on, that's always fun, because here in Florida we're just now getting into this, right, legally. And so there is plenty of evidence that suggests that cannabinoids can be helpful for spasticity and pain. Now that it's now more readily available and legal, I'm starting to now send my patients for that evaluation and starting to see them back. And we're definitely seeing that for some patients, it's all individualistic as well, that they are seeing some relief with the cannabinoids.
Okay, thank you.
Any other questions? There.
Can we talk about biomarkers? Is there anything out there that will predict what kind of MS someone will have and what they will respond to best in terms of their medication? And then with the pediatric population, is there a way to determine what is going to best help them?
So that's where our deficits are, is really understanding what those biomarkers are. There is some research that's going and looking into specific biomarkers. None of them are readily available at this time. Really now our biggest biomarker for disabilities progression and surveillance is utilizing our MRIs. But there are a number of different biomarkers that are under investigation, but none that are readily available for the general population. Pediatric MS is extremely important. I actually see a few pediatric MS patients. And so really our goal in that population is not only diagnosing it as early as we can, because there may be some suggestion that they may not do as well over time, but utilizing or getting the clinical trials out there to show that it's effective, that our disease-modifying therapies are effective in that population. So there are some ongoing pediatric trials looking at our current disease-modifying therapies to see if we can significantly impact them. But at this point, they seem to be very responsive to our interferon therapies, to natalizumab and Gilenya.
Next question here.
It's going to be hard for me to formulate this because it actually involves 3 different things. It's spasms, Botox, and my Baclofen pump. What's been happening is I'm getting more spasms. And when the neurologist said to me, well, she asked, and it was primarily just in an isolated area of my right leg foot. So she says, well, the Baclofen cannot address that because it goes through your whole body. So we tried Botox, and I've had Botox in another area years ago, and I didn't have a problem with it. So when I had the Botox injected into the isolated area, the next day I did feel a little bit relieved in that, but my opposite leg took on very strong spasms, and that really confused me and turned me off to ever having Botox again. And it also, she said, when I said to her, I need to increase the baclofen, she looked at the size of my pump and how much I'm already getting. And she says, I'm kind of like at the limit. I can't give you any more baclofen. So I think I'm in a little bit of a state of unknowing. But I thought maybe you said there might be a procedure for spasms.
So your story definitely speaks to the complexity of MS and how it can affect and how it's uncertain with therapies that we use, that we have one expected result and we get the opposite. But there are a number of different ways, and speaking with your provider, you can tailor that to your specific care. But there are some more invasive things like rhizotomies that neurosurgeons can do that might help to improve that, but obviously that's an invasive surgical procedure. So the procedures that I was speaking to earlier were essentially what you've done: Botox injections and an intrathecal Baclofen pump.
Okay, I want to comment on the cannabis oil. I have a friend who uses it, and she said it's very effective for her pain. She put it on her tongue, she bathed with it, and she would like to expound on it. So we'll give it.
She would like for me to expound on it?
No, we can't do that right now. We can't do that right now. All right, sorry about that. We just can't do that right now, so we got to let the doctor speak.
Yes, very quickly. I wasn't diagnosed till I was 56, and so I'm a very late bloomer in most things in my life, and so I don't know all of the proper lingo in medical terms, but when you're talking about this procedure where you take out the plasma, do you clean the plasma?
Yes, so again, going back to plasma exchange, so that's the nature of the procedure. So what we do is we remove your blood, we clean it, we filter it, we take out those inflammatory cells and cycle it back into you.
So is there any future thoughts of wow, if we can do that, then we should be experimenting on how do we take this all out and get rid of those bad T cells?
Wouldn't it be nice? And I think that might be the foundation of stem cell. So that's probably a more practical way of resetting the immune system, in a sense, is with stem cell transplantation. Plasmapheresis or plasma exchange is a very invasive procedure requiring central lines, and it's not something that's safe to do on an ongoing basis, but definitely I think that's where the stem cell thoughts come from.
And last question, do you have any evidence of, or anything from people who have had stem cell? And it was phenomenal. And it's been a year, and they have no new lesions, and all is well.
So yeah, there are those cases. So there is some thought that the stem cell transplant can be very effective. Right now they're looking at it in relapsing disease. It doesn't show as withholding with more progressive forms of the disease, but definitely you have those patients. But I will say that you have those patients that are free from disease, no evidence of disease activity at 1 year on many of our other disease-modifying therapies. So really, it's an individual approach to that to see who needs something as invasive as stem cell, but isn't it awesome that we have it as an upcoming option?
That's what I'm talking about when I ask you about Lemtrada versus stem cells. Isn't it basically the same kind of procedure?
Not quite the same procedure. So really, I'll preface it by saying sometimes Lemtrada has been used as a induction or a procedure prior to the stem cell. So really what Lemtrada does is it depletes both B cells and T cells, but they repopulate. And we assume under the original circumstances of the body that those T cells and B cells that repopulate will go back and do the same thing. So that's a little bit different than what we would expect with stem cells. So with stem cell transplant, we're taking the very infant cells before they've become anything, and we're hoping that we can train those to become different B cells and T cells so that those B cells and T cells don't go and attack the nervous system. So it's more of if we look at it in a daycare setting, we're not just sequestering the bad kids over here or the disruptive children over here, but we're actually retraining them not to be disruptive. So that's really the difference between Lemtrada and stem cell.
Great. Thank you very much.
Awesome. Thank you.
Thank you for coming to speak with us today. That was great. Thanks a lot. So anyway, I do want to thank you all for coming down here today. Again, I want to thank those that gave us the support to do today's program. I hope that you all enjoy what they did by allowing us to bring this to you today. We got Sanofi-Genzyme, Biogen, and Mallinckrodt. I do hope that you appreciate them. And also remember, please, that we have these seminar evaluation forms. We need you to fill them out. We want to view them, plus those that gave us the support needs to see them as well. So thank you again.